I'm Benita, Olivier. I am a senior lecturer at the University of the Witwatersrand in South Africa, and I've got a special interest in sports injury prevention and sports biomechanics. Today we're going to talk about managing muscle strains using SSTMs, specific soft tissue mobilizations. So what's wrong? You have an athlete that sustained an injury, and of course, as the healthcare provider, this becomes your problem, which is not a bad thing. So let's see what we're going to do. So how will you assess it? Again, with your interview or history or subjective assessment, it's being called various things all over the world and in various professions. So you look at the inciting event, relieving and exacerbating factors, and the timing of the pain. Amongst other things, you do a full interview. And then follows the physical examination where you palpate active and passive range of motion, and you refer for ultrasonography if necessary. So the principle is you do a full interview and physical assessment. Then your muscle strain classifications: grade 1 strains limited to local spasm and tenderness, and the patient may not notice the pain until the day after the injury. Grade 2 strains, palpable area of tenderness and swelling. Passive stretching is usually painful. Grade 3 strains includes tenderness, rupture, or mid-belly tears that's usually accompanied by a visible or palpable defect or deformity. So what do you do with it? So for grade 1 and 2, relative rest, anti-inflammatories, cold packs, compressive soft splinting, if there's hemorrhage and swelling. For grade 2 and 3, maximum immobilization, a rigid splint, sling crutches. Mid-belly tear, often conservative treatment. If there's complete tendon tears, there may be a surgical intervention needed. But usually for a minor grade 1, it resolves in 2 to 4 weeks, but also depending on the grade of the injury and the associated factors. So what should you not do? Do not order radiographs when injury is clearly isolated to a muscle or tendon and there's no bone involvement. So that's just a waste of resources. Do not prescribe or recommend muscle relaxants for acute muscle strain, because they also often use ibuprofen, and that combination increases the central nervous system's side effects. So for today, we are specifically going to look at specific soft tissue mobilization. There's various techniques that people use to handle muscle strains, and also don't forget to include your various modalities as part of the rehabilitation program. Your strengthening, mobilizing, assessing the whole kinetic chain. This is just one specific technique that we are going to look at. So the basis of treatment follows that tissues are subjected to tension, mainly elongation. If not, tensile strength will decrease. The tensile strength allows the tissue to withstand the tension applied from a particular direction, and after an injury, the tensile strength should be restored to normal. Now with SSTMs, there is not a lot of research at the moment supporting or negating it. The theory base that it's based upon seems legit, but we should always remember that as with working with the human body, and there's often lack of research in certain areas, that we can use a certain technique if it's based on a sound theory, if it has not been negated by research. So we need to do more research studies to support SSTMs and to hopefully support SSTMs and to find evidence for its effectiveness. The injury occurs when the load is excessive in relation to the mechanical properties of the tissue, or when the biomechanical properties of the tissue have decreased in relation to the normal load. In managing sports injuries and specifically muscle strains, we have to look at the inflammatory or lag phase, regeneration phase, and remodeling phases, the phases of healing, to judge where we are going to do which modality as part of the rehabilitation process. The inflammatory phase lasts 4 to 6 days. The inflammatory responses are essential for healing. A fibrant scaffolding holds the wound edges together. It's fragile and easily disrupted in this inflammatory phase, and there's no increase in tensile strength. And we have the principle of RICE, or the latest price or police. Sure, you've heard of all those acronyms. ultrasound, laser, anything to help decrease inflammation and increase the healing process. So the regeneration phase from day 5 to 10 to 12 weeks post-injury, greatest increase in the tensile strength during this time. The fibroblasts lay down collagen. There's random orientation, but it restores structure, but it hinders function. So as the collagen is laid down, it restores the structure very well, but it hinders the function. So the extensibility, direction of the collagen fibers should relate to that of the undamaged tissue. And that is what we're going to aim with SSTMs. So during the regeneration phase, there should be careful tensioning to promote the correct alignment by remodeling of collagen. Lead to earlier increase in wound tensile strength. After the 3rd or 4th week post-injury, collagen synthesis is matched by collagen lysis, which means that there's a stabilization of the collagen lay down and in the injured muscle tissues. Tensile strength still increases, but it's not due to the formation of new collagen fibers, but rather due to the cross linkages which forms between these fibers, which restores the structure, and we're going to work on restored function as well. During remodeling, 21 days to 10 to 12 weeks, and you can see the overlap between the regeneration and the remodeling phase. And so it depends on internal or external factors, the extent of the injury, the health, general health of the athlete, age, in which phase an athlete is. The collagen synthesis is matched by collagen lysis in this phase as well. But as the tensile strength increases, it increases at a slower rate than during the regeneration phase. So you almost approach a plateau in the increase in tensile strength. The cross linkages strengthen the wound but also lead to adhesion formation, which causes restriction of motion and makes it more vulnerable to re-injury. So during the remodeling phase, there's a tendency for wound contracture, and it may last 6 to 12 months post-injury. The remodeling of collagen fibers takes place, continually adapting to the stresses to which they are subjected. A very important principle that we have to remember when we're using SSTMs. So prevention of scar tissue contraction is needed in this phase, and promoting of the correct orientation. And this is part of the principles that SSTM is based on. So here you can see the tissues nice and normal. There's tissue overload, and you get your injury. Going through your lag or inflammatory phase, go to regeneration and your remodeling phase. So there's 3 different types of SSTMs. We've got the physiological, accessory, and then a combination of the two. Physiological SSTMs make use of physiological movement like flexion, extension, adduction, internal, external rotation. Longitudinal passive stretch to the tissues are applied. So for example, if you put tension in the rectus femoris because you have got an injury in the rectus femoris, hip extension and knee flexion with adduction or abduction to localize the site. And if you have a muscle strain in the biceps femoris, you do exactly the same. So the patient will feel the stretch over the affected area, and you need to move the limb in such a way that the patient feels the stretch exactly at the right spot. So the principle is not to just give for a hamstring strain, tell your patient, go home, do a hamstring stretch. But you need to teach your patient to slightly move the limb, hip flexion, adduction, maybe a slight internal rotation, so that the stretch is located exactly at the spot of the muscle strain, to help with increasing the tension that the muscle experiences, and in that way increasing the tensile strength. So check for these compensatory movements while you're stretching, so that you make sure that they really feel it at the exact same spot as the injury. Go feel the stretch exactly at the correct place. So accessory SSTMs, And that's moving the tissues, so there's a longitudinal stretch of the tissues transversely to the line of the collagen fibers in the same place as the plane as the fibers. I'll show you a picture just now. So the therapist applies the stretch to the patient muscle exactly on the spot of injury. Tissues. Tissue is put under tension by using a passive physiological soft tissue mobilization technique. You use a combined technique. So you put the patient's arm or leg in a certain position, and then you do the SSTM while in that position. So this is when you progress a bit further. How do you apply it? So it's an oscillatory force, days 6 to 14, and a sustained force as you progress into more resistance. The grade of force is a grade 2, in other words, not into resistance, slightly off resistance, just causing slight discomfort, not causing necessarily pain, for days 6 to 14, and a grade 4, which is a bit more into resistance for afterwards when you progress. Direction of application, where the comparable sign is elicited. So that's where the patient feels their discomfort or their pain. And 30 to 60 seconds every 2 waking hours if you send your patient home with a home program. This is a nice article to read which explains the specific soft tissue mobilization technique very well. Thank you very much. I hope this answered your questions, and go and try it out. See how your patient responds.